Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of invasive breast carcinoma, ductal carcinoma, associated with sclerosing adenosis, a potential pitfall. So this is a case of a 44-year-old female patient who was found to have left breast lesion. Even on imaging and the initial biopsy from the breast mass actually, or the breast lesion, was negative, but because of the irregular appearance of the breast lesion, they elected to go for an excisional open biopsy. And as you can see here from the low power magnification, this is quite a busy breast tissue. Let's zoom in. This is actually a focus of ductal carcinoma in situ, surrounded by cords and glands of invasive ductal carcinoma. Let's focus in or zoom in more. These are the invasive ductal component that is composed of cells, some variation in the nuclear size. When we compare the nuclear sizes of the adjacent cells, not much in the way of a pleomorphism, and again we do not see really much in the way of mitosis. So we have like alveolar or solid gland-like structures that are lacking the lumen, some a low degree of a pleomorphism, and not much in the way of mitosis. And these are features important to render or to assign the appropriate grade for the tumor. Again, another focus of the invasive ductal carcinoma, where we have like nests of tumor cells that are lacking a tubule formation or a proper gland formation, but not much in the way of mitotic figures or even a pleomorphism. And yet another focus, but what is important here is that the stroma in between is really sclerotic, and this sometimes can hide the tumor cells if we don't pay attention, especially if the tumor load was really not high. Now, what was really supportive of the presence also of invasive ductal carcinoma is the presence of lymphovascular invasion. This is a tumor embolus, and this is the rest of the wall of the vessel. And in order to be sure that this is a real vascular invasion, part of the tumor has to be attached to the wall of the vessel, at least at one focus. So this was actually at the edge of the tumor. Remember, lymphovascular invasion should always be evaluated at the advancing edge of the tumor, not within the tumor. So far we have an invasive ductal carcinoma that appears to be like grade 2 with evidence of a lymphovascular invasion. Now, these are the foci of the ductal carcinoma in situ. These are the expanded glands that are completely, the lumen is completely obliterated by proliferation of more or less similar tumor cell to the invasive component. Here they are forming some glandular structures, and then we have lots of necrosis within the lumen, but these are all confined within the space of the duct, and these are actually the myoepithelial cells that would really give the assurance that this component is the ductal carcinoma in situ. Now, in another focus of the tumor, there was this very florid growth. And again, to the junior pathologist or to an unwary pathologist, this might be confused with invasive carcinoma. But actually, if you just zoom in into the high power, we have calcification, but we have epithelial and myoepithelial cell layer. So this is the dual lining that we usually see or typically see with the benign breast proliferation. And this is again another focus more towards the center of the lesion, where we have lots of sclerosis, and then we have adenosis, which is proliferation, florid proliferation of the glands, but these are benign glands. Epithelial and myoepithelial cells, epithelial and myoepithelial cells surrounding these glands. What was really very peculiar about this case is that at one focus, half of the lesion was actually the sclerosing adenosis, and half of it was involved by the ductal carcinoma in situ. And then we have the invasive component just just outside the confines of the mixed sclerosing adenosis that is involved by ductal carcinoma in situ. This is very tricky because if this was the only lesion present, it sometimes might be difficult to separate the sclerosing adenosis, this part of the lesion, the benign but exuberant proliferation of the glands, from the malignant ductal carcinoma in situ or even invasive carcinoma. Now, to zoom in a little bit, this is the benign component where we have the epithelium surrounded by the myoepithelial cells, and then we have, you can see the contrast. This is the part where there is only ductal carcinoma in situ, and in which the proliferation within the ducts is only composed of the epithelial, malignant epithelial component. The myoepithelial component will just be only present at the very edges of the proliferating glands. And then again, zooming in, you can easily appreciate the difference between the nuclear size, the arrangement of the tumors here, for example, between the DCIS and the florid epithelial component. But in order to ensure that we are really rendering the proper diagnosis, and remember, this is extremely important, especially if we have limited biopsy, not to overcall or undercall the lesion, and also whenever we have excisional biopsy, in order to estimate the proper size of the invasive component, we have always to exclude the benign component, especially when it is at the edges of the lesion. So our dear friend, P63 immunohistochemistry, that would show or label with a nuclear stain the myoepithelial cells. This is the typical appearance of sclerosing adenosis, where on high power magnification, the negative nuclei are the benign epithelium, and the staining nuclei, the nuclei with the brown color, are the myoepithelial cells. And of course, because this is so florid and because of the sclerosis, the benign glands are drawn together, we can see as if there is an overestimation or over-representation of the myoepithelial cells. But in order to ensure that our interpretation is proper, we have to see the negative epithelial cells in between the positive myoepithelial cells. Now, the P63, remember, it stains the myoepithelial cells in the normal breast lobule, while the epithelium is completely negative. Now, in the ductal carcinoma in situ, the tumor cells that are forming the DCIS are negative, whereas we look at the nuclear staining for the myoepithelial cells at the edge of the tumor, at the edge of the proliferation. Now, another very interesting pitfall that was seen, potential pitfall that occurred in this tumor, this is the invasive component. And as is well known for most practicing pathologists, that P63 is a nuclear stain for myoepithelial cells. However, in a small minority of invasive ductal carcinoma, P63 can be positive in the malignant invasive cells. So these are the malignant glands actually, and they also stain with P63. So if you do not know, if you are not aware of this potential pitfall, you might end up calling the whole lesion as benign sclerosing adenosis with some ductal carcinoma in situ because of the wrong interpretation of P63. How would I really ensure that I do not commit such a mistake? Because there are no two components, the same tumor cells that are forming the glands, the malignant glands, are the ones that are taking or are labeling positively with P63. Now, ER would be very helpful in this context because invasive, especially the low-grade invasive ductal carcinomas, are usually strongly diffusely positive with the ER. Remember that this is not the case with benign lesions in the breast, where we tend to see the mosaic staining pattern. PR also is strongly positive, and these ER and PR in this pattern of positivity would strongly support that these basic glands, although they label the cells themselves with P63, these are malignant and not benign glands. Now, HER2/neu, this also almost is considered a negative or 1+ HER2/neu interpretation. Remember nowadays that we assign these the 1+ HER2/neu positive tumor invasive ductal carcinoma cases into low, we call them low expressors, because of the availability of conjugated treatment for the low expressors of HER2/neu, especially the 1+ cases. So Ki-67 also is nowadays routinely done in most, if not all, invasive breast carcinoma, because it helps to better assign the tumor into the good versus the bad prognosis cases. The cutoff usually is 14%. We have to evaluate only the invasive component. These are the tumor or the foci of the invasive component. And as you can see, the estimation was definitely less than 10%. So this is less than 14%, the cutoff that is usually used to differentiate the aggressive tumors, luminal B type invasive breast carcinoma, from luminal A, the good prognosis breast carcinoma. So the final diagnosis in this very interesting case is invasive ductal carcinoma that is a grade 2 associated with sclerosing adenosis. Remember that P63 is very useful to differentiate between benign conditions versus ductal carcinoma in situ, in which we see usually the myoepithelial cells being positive while the epithelial cells are negative, and the vast majority of invasive ductal carcinomas are negative for P63. However, a potential pitfall is that on occasions, the invasive ductal component cells themselves, rather than the myoepithelial cells, can be positive with P63, a potential pitfall that you should pay attention to. Please remember that sclerosing adenosis can be associated with ductal carcinoma in situ or even invasive ductal carcinoma. So you have always to look at low power magnification. Then you have to verify the presence of epithelial and myoepithelial components at high power magnification, and then apply the appropriate immunohistochemistry. Remember that ER and PR, especially when they are strongly diffusely positive, usually this is supportive of an invasive carcinoma, or of course ductal carcinoma in situ, but in this context invasive carcinoma, because of the presence of the P63 labeling the invasive carcinoma cells themselves. And remember that HER2/neu nowadays, even the 1+ has to be mentioned meticulously, because specifically because of the availability of targeted or conjugated treatment specifically for the low expressors. And remember that Ki-67 can be helpful to separate luminal A, the good players, from luminal B, the more aggressive type of invasive breast carcinoma. I hope you find this tip useful in your daily practice. Thank you.